We're going to do EENT, and this is mainly going to be looking at the upper airway up above, and then we're going to go into respiratory following that. So let's take a little journey through this. And I also had a nice question just a moment ago about medications. You notice we don't have a lot of medications per se that we're needing to spend a lot of time reviewing. I just wanted to share with you there aren't a lot of medications, and if they do have a medication, typically if it's a trade name that's on there, they'll give you also the generic name. We're getting ready. I mentioned acetaminophen earlier. Getting ready to do otitis media. We'll probably think about augmentin, higher doses of augmentin if it's appropriate. Those kinds of things. Now, we did do a lot of things in the skin area, which talked about a lot of different topicals. Even though we did go over some skin medications, there are not a lot of, the question is not directed on the medication. It's more on the type of treatment that you might involve in. Does that make sense to you? So I don't want you to think, and there's very little like calculation, so I just want you to know that. All right, so let's do eye, ears, nose, and throat. We're going to start off with the eye, and we're going to start off with the good old-fashioned sty, Hordeolum, right? And this could be a staph infection, extremely common. Look at this young lady here. She almost looks like she's kind of smiling at you, but she doesn't want you to come near her, right? But that eye is exquisitely painful. It's because of the amount of pressure she has in the eye. So you want to think about in your differential conjunctivitis, a chalazion, which I'm going to talk about in a moment, which is going to be more of a non-painful, itchy, beady nodule. Blepharitis, which is the eyelashes are infected and inflamed, and Dacrocystitis has to do with the lacrimal apparatus. This is usually an abrupt onset pain edema, pain proportional to the amount of edema that you have. What you want to do is you want to have the parent, the child, use warm compresses to bring it to a head so it opens. Also Bacitracin, erythromycin, ophthalmic ointment, and will be in order, and usually you give them about 48 hours to see if it'll open. Otherwise, probably need to refer them over to ophthalmology for an IND. Usually ophthalmology for an IND. Now, this is that beady nodule that we talked about. It's a granular inflammation of the meibomian gland. Often does follow somebody that's had a hordeolum, a sty. Maybe signs and symptoms may be none, red conjunctiva, itching, visual distortion, depending upon how large it is. I've seen some very large ones and some very small ones. Eyelid swelling, light sensitivity, increased tearing. Usually these are the folks that definitely, you can give them warm compresses for comfort, but it needs to be surgically removed by the ophthalmologist. Do you think you're going to have conjunctivitis in primary care? Oh yes, pink pig, okay. So you think about this, pink eye is the common term for this, and you can have an allergy, chemical irritation, some type of an infection, either bacterial, viral, and the bacterial can be something like a gonococcal or chlamydial, and there are certain ones that you want to treat as an eye emergency, such as a gonococcal, chlamydial, and herpetic. Have you ever seen a herpetic conjunctivitis? Is a very beat, bloody, red, irritated, very, very uncomfortable eye infection. So you think about the signs and symptoms, pretty much itching, burning, increased tearing, blurred vision, eyelid swelling. They'll tell you that it feels kind of like there's something in my eye. I can't quite get it out. They may have an injected sclera. Eyes may be a little crusty, sticky, maybe some discharge. It may be clear, stringy. And you know, clear and stringy is probably going to be more like an allergic type of a reaction. Watery is more viral. Mucopurulent, of course, is bacterial. And you've got a chart that is available for you that you want to think about how to treat them when you think about conjunctivitis. So as we look at this chart, excuse me, when you're looking at your chart in here, you're going to think about, you know, what type of discharge. Usually with a chemical, you want to flush the eye. You want to think about bacterial. Was it purulent or copiously purulent? And we've got some choices like erythromycin, tetracycline. We think about polymyxin B, ophthalmic solution. But if it is going to be a chlamydial one, you need to use good old what's the standard? Rocephin. We think about chlamydial, we've got several choices here like your tetracycline, erythromycin. Allergic, now the allergic one, usually oral antihistamines will be appropriate for this, but if there's a need for, if there's like swelling and you need some steroids, we never, ever, ever put steroids in the eyes in primary care. That is always a referral out. And if you don't know, just send them to the ophthalmologist. But the reason is steroids in primary care is it increases the intraocular pressure and can also activate a herpes virus. So you want to be very cautious. Viral, well, viral is usually more of that watery kind of discharge. Usually a lot of comfort measures like just rinsing the eyes, saline drops, artificial tears. It's always nice to tell them to put them in the refrigerator because it's more soothing to have something cool. Moderate, you can maybe think about decongestants. And then some folks are concerned, especially if you have somebody that has recurrent viral infections, is think about perhaps putting them on sulfacetamide solution. Some people know it as Blef 10. And that has been used very nicely to prevent any, it's like a prophylaxis for any bacterial infection. And herpetic definitely is a referral out to the ophthalmologist. So you know you're going to see this in practice. Now cataracts. Cataracts, we often think of cataracts with the elderly. Well, cataracts can also be congenital. And I don't know if you were familiar enough to think about, but comorbidly, cataracts are found with kids that have Down syndrome, diabetes, Marfan's. Remember we said eye involvement and atopic dermatitis. So you may see those being associated, and we know it may be congenital, or this is one of the reasons why we're very cautious about what? Prolonged steroid use. We don't want to prompt this. Radiation. This is why it's important for all of us to protect our eyes with good, use of sunglasses. We also think about, it's usually painless. There's that cloudy, blurred, fundal white fundus reflex that we have when you're doing your fundoscopic exam. Photophobia, poor visual fixation, because it's like they have to look through that cloudy area. Pretty much, what do? You refer them to ophthalmology, the surgical intervention, and so forth. Again, I saw a lot of kids in Haiti that had had cataracts. Now, this is a pink pig. Strabismus, okay? You're thinking strabismus, okay? Well, this is a very keen eye developmental condition. This is where you have ocular misalignment, uncoordinated ocular muscles, and if acquired after the age of 6 months, there's usually an underlying problem. We think about kids that have strabismus, they squint, they have decreased visual acuity, they tilt their head, they do face turning to try and see if they can align, because remember the eyes are not aligned. Esotropia, exotropia, hypertropia, and hypotropia. I'm going to let you kind of think through. We're going to look at some visuals for this. And the good old Hirschberg papillary light reflex is unequal. So we think about, now it's a little bit, when we think about how the eyes turn, eso means inward, see that one there, and then outward. And you know it's hard when you have somebody, I have a colleague, a nurse practitioner friend, who has a very significant exotrophia. It's really hard to communicate because you don't know, it's kind of hard to kind of fixate yourself on, you know what I'm saying? Because we are driven by looking at people and their eyes and so forth. But that's important. Hypertrophy up, and then hypo, oops, I really got carried away there. Hypo is, there we go, hypo is downward. Now, what you want to think about is, here is what is different about this child. Now, this child has retinoblastoma, which we're not going to get into per se, because we're not going to treat retinoblastoma. But what do you see that's unusual about this child? Well, eye color, right. Now, that's kind of getting into the retinoblastoma. The eye is darker. It's hyperemic, so it's very bold in its color. And I don't know if you can see, but there's the actual tumor. You can see the tumor through the eye. What about the lights? Right. This is a classic Hirschberg papillary light reflex is unequal. So even though it's with retinoblastoma, I was using it just as an example. kids that have retinoblastoma, and that anybody that has an unequal light reflex typically has strabismus. They're not aligned. The eyes are not aligned. So what you want to think about is the goal in treatment is, when do you refer them? Well, we give kids up to 6 months to garner alignment. After 6 months, you need to refer them out because they'll probably need to do some type of patching, eye exercises, and so forth. And anytime you have hyper or hypotropia, the reason for those two is because those are often associated, when the eye goes up or down, you can have space-occupying lesions, hemorrhage. What's a space-occupying lesion? Would be a brain tumor. So they want to make sure that they are followed very closely with that. It could be a blockage with the, remember the choroid plexus makes the cerebral spinal fluid and so forth. So you want to think about what is causing this eye to misalign. So we're going to kind of come out of eyes and we're going to go into ears. And you know we're going to start off with otitis externa, swimmer's ear. The external auditory meatus is inflamed. What causes it? Could be infections such as bacterial, fungal, or viral. Fungal, usually you're going to have a little bit of an odor, and the ear canal is going to have, when you're looking at it real carefully, you're going to see in the fungal, it's going to have along the little, where the hair follicles are, it's going to look like little black pucks all in the area. So smell and little black specks that are peppered in the ear canal itself. Usually, and also sometimes swollen. Recent history of water exposure or mechanical trauma. Kids who have emotional disorders or upset emotionally often put things in their orifices, right? So they put things in their ears, and so forth. They're going to probably have some pain, pruritus, purulent discharge. You think about erythema, edema, may have the odor. When you move the ear, the tragus, the pinna, that itself is going to hurt, because you're moving the ear canal. The TM really usually is normal. It can be a little erythematous, but it's not really infected. And remember, we don't always rely on, anyways, a TM that's red only by itself, because the kid could be excited, crying, upset. The TM is really considered normal. What I mean by normal is, what is a standard of practice for assessing the ear? You always want to look at the TM's mobility. So that's a standard of practice. Not always do we do that, do we? We don't always use the insufflator bulb to check mobility of the TM. But you really should check it and document TM mobile, clear, translucent, COL noted, things like that. So we think about, there it is, pneumatic otoscopy demonstrates the mobility. If you have an ear canal that's affected, remove any debris, moisture injury, protect it. And then good old ear drops, like some of that are suggested here, bacterial acetic acid with hydrocortisone, which helps with the swelling, and also corticosporin. We think about fungal, they're probably going to need some, an azole, like a chlorotrimazole would be a good solution choice. So we're going to move into otitis media. Acute otitis media is usually a bacterial infection, and earlier today I mentioned how strep pneumonia 30% and H influenza 20% are major organisms that cause otitis media. They're also, even though we haven't done pneumonia yet, are the major organisms for pneumonia. Signs and symptoms: decreased hearing, pain, which is otalgia, fever, oral pressure, vertigo, and nausea, vomiting. Now that eardrum up there, erythematous, edematous, it may be taut, have little flexibility or mobility. It rarely bulges. It may be more convex. It may be like it's drawn back in. It doesn't have good mobility. Impaired, when you do your insufflator bulb. So what are you going to do to manage it? Well, you want to make them comfortable, so acetaminophen, maybe some benzocaine otic drops would be helpful. Oftentimes, parents come, it's almost like the minute the kid says his ear hurts, they're in your office. And we don't always have, not everything is always caused by a bacterium. I mean, it's got a pretty good thought there with 30 and 20%. But oftentimes we suggest 48 to 72 hour watchful waiting, because they've actually done studies on this and found 83% of them were actually viral and did not need an antibiotic. If an antibiotic is needed after, say, the 48 hours or so, 72 hours that the child is continuing, they're worsening, they're developing a fever and so forth, think about your amoxicillin, 80 to 90 milligrams per kilogram per day, twice daily times 10 days. And then, of course, we've got good preventive measures like your Hib, your Prevnar, and your annual flu vaccine, and try to avoid secondhand smoke. That will also help. Now, what about if you have Serous Otitis Media with effusion? This ear is going to look a lot different. This is known as chronic otitis. It's a blocked eustachian tube. It has difficulty equalizing pressure, maybe allergy or a neoplasm or a subacute infection. Look how different that eardrum looks. Okay? Very full, and sometimes you can see, when you get really keen at looking at ears, you can sometimes see behind the TM, you can see some purulent matter. Air bubbles may even be seen, like in this gelatinous middle air here. Decreased membrane mobility, and the Weber, and how do y'all pronounce Rhine, Rennie, Renee? How do y'all pronounce that? Rhine? Okay. It's so funny because wherever I go in the South, Renee, I've heard Renee, I've heard Rennie, I've heard all kinds. So anyways, but they do occasionally ask questions about the use of a tuning fork. One of the questions that I thought was really interesting, because they ask a lot of anatomy physiology questions occasionally. One was, which of the 3 middle ear bones touch the umbro of the TM? Y'all know what that is? What are the 3 middle ear bones? The stapes, the anvil, and the malleus. The answer is malleus. So if you go look up that, and I thought, oh my gosh, that really stumped me. I had to really think about it, because I don't remember which ones they were. You know what I'm saying? So that's just a little thought I'm going to pass along to you. And we want to think about decreased hearing via audiometry. You know, when you have somebody that has serous, it's chronic, watchful monitoring, monitor them for 3 months. Sometimes kids, one of the things that we found has been really helpful for kids that have chronic otitis media is to have good old saline rinses of the nose. But sometimes you got to get the kid in a headlock, right, to do that. But we know how important it is just rinsing the sinuses and so forth. And usually antibiotic therapy has no long-term efficacy. Antihistamines and decongestants are ineffective. They only make the kids crazy, bouncing off the wall. And reevaluate 3 and 6 months. So you're just kind of monitoring that. But you want to think about what impact does this have on their language development and hearing loss. So let's think about how we're going to assess this. Is it conductive or sensory neuro? And you think about conductive causes. Could be cerumen, foreign body, otitis media. And I have to tell you, one of the stories that I had with foreign body, I used to do medical management for a hospital when I lived in Atlanta for kids with emotional disorders. It was a hospital where kids were in for treatment. And there was this one little girl, she was 14, she's not too young, but she was 14. She had put 6 or 7 green Skittles in each of her ears. And actually a couple of them melted. Can you imagine? And I was like shocked when I looked in her ear. And so you want to think about, you know, kids do that. I had another kid that put, you know, the colored popcorn? He put that in his ear. He said they jumped in there. You know, he was like 3 years old. They jumped in there. Don't you love to, now how did they get there, you know? And so otitis media, foreign body, tympanic membrane can be perforated. You can have this process of osteosclerosis, progressive deafness due to overgrowth of the bone in the inner ear, and then this cholesteatoma, peeling layers of scaly keratinized layers of epithelium that erodes the ear and leads to deafness. That can be very serious. So you've got varying degrees that will affect hearing. So we think about sensory neuro. Well, sensory neuro is really more serious because it involves the nervous system, acoustic neuroma, syphilis, CNS disease, medication toxicity. What med usually causes this? Your aminoglycoside group, right? Like your gentamicin. Have you thought about that? Now, just to kind of help you think about how to do your tuning fork, understanding Weber and you all mainly call it Rhine here, right? Rhine is how you do it? Okay. So we'll go with Rhine, but some people refer to it as Renee and Rennie. And you're probably saying, well, which is the correct way? Well, the correct way is really Rhine, okay? So I just wanted to let you know that. The normal findings, when you do the Weber, the way to think about it is you tap that tuning fork, and if you think about, see how you put a bow? We're doing pediatrics, so we have to make this fun. You've got a bow on top of the head, the W, okay? When you tap that tuning fork and you put it in the middle of the head, like a bow on top of their head, it should equally lateralize to both sides. That's normal. When you think about the Rhine, that is the one when you tap it and you do what? You put it where? You put it on the mastoid, and once it stops, you stop the feel of the vibration, you put it to the ear, and you should still hear vibration. So that means air conduction is greater than bone conduction, AC greater than BC. So that is normal. When you think about, and so we've kind of gone through, you know, what's normal and so forth, but what about if, oh, excuse me, let me go back up. What about if you have conductive hearing loss? What you would see is sound lateralizes to the affected ear in the Weber, so it's going to go to one side wherever it's affected, and the Rhine, the AC will be less than the BC. Sensorineural, really the Weber will lateralizes to the unaffected side because that's the side that can transmit sound, and the Rhine is normal in the affected ear. So if on occasion they ask you a question, you're prepared for this, you know, this test question. Otoscopic examination, doing a neurological examination, doing your audiometric testing. Maybe if you're concerned about like something in the brain, like a brain tumor, or perhaps maybe some serum blood testing may be in order for syphilis testing would be important. You know, if you got cerumen or skittles or whatever you have in the ear, they need to be removed. Audiogram, and also when you think about further evaluation, they may even need a hearing aid. Now, common cold, I am going to kind of have us not spend a lot of time with this, but we know common cold, rhinorrhea, and mainly, you know, cold-like symptoms and so forth. They feel kind of miserable because little children, the younger they are, the smaller the space is for them to kind of move these secretions around. Rest hydration, there's your good old nasal saline drops. Really no OTC cold preparations, even though they still have a lot of them on the market. Remember they had that year when they took everything off, all these, you know, notices that we were not recommending them, because parents get what? Overwhelmed. They go in, they go, oh my gosh, is it Robitussin D, DM, you know, all the different codes and acronyms. So it's just been recommended basically saline drops, humidification, fluids, and really no antibiotics because common cold is typically viral. Now, what about epistaxis? Now, there's been a question a time or two on this, and we need to know about that's bleeding from the nostril, drips down into the stomach, back of the throat, and you think about what are you going to teach the parent to tell the child to do, and when you're working with them, sit upright, pressure at the Kesselbach's triangle. What that is if, as it says, is the anterior inferior aspect of the nasal septum. So if you take your finger and slide here, right there, your nose is highly vascular. So it's just by sliding into that little juncture at the edge of the bony ridge and hold it for 10 minutes. Also use ice. And this is a good thought about how vascular the nose is. So if you hold pressure, you're going to stop the bleeding. Okay? Now the throat. Pharyngitis tonsillitis. Well, we've got a lot of organisms that can cause viruses is pretty common, and a lot of times people that start off with a sore throat, then they go into cold symptoms. Often it's usually viral, but group A strep infection, your mycoplasma, chlamydia, you've got lots of different organisms. Pretty much as you look through this, when you have dysphagia, cough, malaise, you can have rhinorrhea, which is more of the viral. The fever is really going to be more pronounced, more in a higher like type of fever, not something mild, bacterial. And remember earlier I talked to you about adenopathy, but anterior cervical adenopathy is mainly bacterial. So when we think about this in the anterior adenopathy versus posterior, posterior is more viral. Like when we talk about mono in a few minutes, it's mostly like a Epstein-Barr virus. It's very common. Painful throat, exudate. Not everybody has exudate. And I know that we're talking about, this is a good way, Centaur criteria. Dr. Centaur, he's a real person that practices at the University of Alabama in Birmingham. He's a wonderful speaker if you ever get a chance to hear him speak. But he came up with this little mnemonic for you to think about with a group A beta-hemolytic streptococcal infection is the flea criteria, which typically means if you have a fever, lack of cough, exudate in the pharyngotonsillar area, and anterior cervical adenopathy, probably you want to start thinking about maybe the person has some type of a strep infection. One other thing, I got strep this year, and I had forgotten about it. Kind of took me over by surprise. On my at the base of my lower leg, I had a very flat, macular, hot red rash. Rash goes along with strep infection also. I picked it up from one of the kids. I was so sick, but that is something too you might want to add to. And sometimes with strep you also have GI disturbance. GI and rash can also go along with this. You know, it's kind of like we're trying to figure out, you know, what do you have? And so if you're going to treat somebody, usually we don't always run off and do a throat culture on everybody. Unless there's a lot of times now they recommend doing throat cultures after you try to treat them either symptomatically or if you put them on an antibiotic if it's warranted and they don't get better, then you do the throat culture. Oh, so there you go. That's showing you, you know, throat culture only is suspicious, and again, usually for non-responsiveness. Fluids, warm saltwater gargles, boy, is that helpful. A lot of people don't realize the benefit of that. That's really helpful. Antipyretics. You know, for your strep infection, you got your penicillins, and then again, you could use your erythromycin. Those would be some good choices. Now, epiglottitis. So we're still talking about the upper area, but we're now starting to get into some respiratory distress. And we're going to compare and contrast epiglottitis to croup with this. Sudden severe swelling of the supraglottic structures due to bacterial infection. And you can see here strep, pneumonia, influenza, 6 to 10 years of age. Look at how swollen this is. If you were going to do an x-ray of this area, it's called a thumb sign. Y'all remember that? And doesn't it look like a thumb coming up through that? Doesn't it? It's so, the supraglottic region of the pharynx gets extremely swollen. It's very responsive. And so this is the kid that you're in the waiting room. You're looking out in the waiting room. This is the kid that's sitting like this, hyperextending his head because he's trying to breathe. Okay? Because he's having choking, he gets fearful, he drools, high fever, can show rapid signs of respiratory distress. These are kids that you don't need to do a pharyngeal exam on. You need to quickly get them hospitalized, perhaps intubated, and also get some cephalosporins IV on board while you're waiting for the cultures to come back and tell you what the causative organism is so you can be more specific. Now, croup. Croup is a little younger child. It's really, if we compare these two, you've got epiglottitis, mainly bacterial. Croup is more viral. Bacterial is rare. Supraglottic versus the larynx. Now, if I could have you jump down here and think about this, thumb sign versus steeple sign. When you have a child that has croup, makes this long, drawn-out sound. They go, it's like they're drawing their air through some swelling. And so what it is at the larynx, swelling occurs on the outer side, and it pushes the larynx like this. It makes it narrow. And that's what it is. It's that air drawing through a narrow area that causes that croupy sound. You can see here younger children for croup, 3 months, 6 years, 6 to 10 years. High fever, drooling, and then maybe more of a barky type of, a stridery type of cough. Okay? Now, infectious mono. This is where we got the good old Epstein-Barr virus, saliva. In other words, a child who gets exposed to this needs a pretty good dose of it. Somebody has Epstein-Barr, they need to drink or eat after them to get a pretty good dose. You know, they used to call it the kissing disease. Kids who have Epstein-Barr mono are exquisitely ill for a long period of time. And they have malaise and fatigue that can last for months. They may have this exudate in the pharynx. The pharynx may be very swollen. I had somebody in the other day that had 3+ equal tonsils, almost 4+. So that's a kid that needs what? Steroids, right? So physical findings, cervical adenopathy, lymphadenopathy, the tonsil exudate, enlarged spleen, and a rash. And the rash can be either a macupapular or more of a petechial rash over the trunk. These are kids that are going to have, instead of like you think about neutrophilia, with the neutrophils are increased, they really have more of a lymphocytic leukocytosis. The lymphocytes are always elevated, okay, when you're looking after their CBC with diff. Their heterophil monospots are positive. They're going to probably show an early IgM rise. IgG will be permanent. So once you've had it, it will always be noted. Pretty much how we manage them is supportive measures with gargles and steroids, especially if what? It's blocking or near blocking the airway. You can use these antiviral, penciclovir can be used, not routinely used though. But it's a virus that has to run its course. Kids who have this condition need to be avoiding what? Contact sports, right? For how long? They suggest up to 3 months. So if you have somebody that's playing, soccer or something like that, you've got to think about that. Now we're getting ready to embark upon sinusitis. One of the things I want to tell you about sinusitis is we know that it's that collection of pus that accumulates in the perinasal sinuses. And the reason it says 9 years of age or older is because, let me tell you this, in your differential, you probably would not have sinusitis in kids younger than 9. The reason is, young children have what we call honeycomb sinuses. They're very open honeycombs, so in other words, they can fill up with a lot more. It's not until around 9 that these honeycomb sinuses become more of a cavity, so that when you fill up with, pussy fluid and everything, it has no way of getting out. Does that make sense to you? So be cautious of that on a test question if you have like a 6-year-old and which of the following are in your differential diagnoses? Sinusitis may not be one, okay? Maxillary ethmoid sinus is most commonly affected. There's your strep pneumonia, H. influenza, M. cataralis. Pain, pressure, discharge, drip, cough, pain, such as throbbing pain, worse as the head's dependent. Pretty much when you think about your lab and diagnostics, a lot of us rely on what the clinical presentation, if need be, especially if you have somebody that's not, responding to your treatment, perhaps maybe CT scan of the sinuses. Yes, you could culture the purulent, nasal discharge. A lot of folks, that's not real standardly done. And again, that's showing you the honeycomb appearance for the cavities. When you think about managing, good old amoxicillin or erythromycin for 14 days, decongestants and antihistamines typically don't help a lot in acute, but they help more in chronic. Pain, managed by acetaminophen, your humidification, supportive care. And you know what? We manage sinusitis often in our practice. It's just that child that you just can't seem to get cleared up that you would go on and refer to the ENT specialist.